just
Oh yeah, sure.
have questions. Make sure
Sure.
you ask them this and make sure you ask
no
them
problem,
that.
No problem.
Okay, go ahead.
Yeah, so, we looked at it, we've presented your case to the tumor board, and we've looked at the MRIs and the CAT scans and everything, and what it appears to be, it's invading the base of the bladder, okay, and also the sphincter muscle, where that keeps the urine in the bladder. And I could kind of tell it when I was resecting your tissue. You did the right at the tip there, we call that the apex, or the viru, definitely looked, abnormal, and that's kind of the back end of the prostate, okay. The problem with that is the sphincter muscle is what keeps the urine in the bladder. Okay, so if it's invading that muscle, you have to take that out, and if you tried to connect the bladder back to that, you'd be totally incontinent. Okay, because you'd have no sphincter muscle or anything, and that's just a very difficult way to live. And the fact that it's invading up where the ureters enter into the bladder is also a concern that we could probably not get negative margins in that area, because the ureters are right there. I remember when we looked in your bladder, you could see that the tumor was right there, kind of next to the ureters. Okay, so and it's a very, as you know, it's a very unusual tumor. I mean, this is just not many people have experience with this. So it's kind of your first shot is your best shot at trying to cure this. Okay, and
so are we saying remove the bladder?
we're saying remove the bladder. Yes. I think that's pretty much what we have to do in this setting. We've all looked at that. Our group has looked at it, and we feel that it's just not possible. Now, if you obviously want to go to, you talked about going to, what was it, to Cleveland Clinic or something, and see if they
60 miles away.
Right. So I mean, I have no problem if you want to get a second opinion there. They obviously can also advise you. I mean, it's not something that I've never seen one. Okay, this is a very unusual kind of tumor.
Yeah.
But I know from what I've read about it and everything that your first shot is your best shot at curing it. And from what the X-ray shows, I don't feel that we can get negative margins. And it's all about surgical cure, because there's no really good chemotherapy or radiation or anything for this. So it's all about trying to be able to get rid of it all with the surgery. So
the question my sister keeps saying,
right.
Ask him about alternatives.
Right.
There aren't any.
Right. I don't see any. I don't see any. When you remove the bladder, there's alternatives as far as what you do with the diversion of urine away from the way. And there is something called a catheterizable stoma, which is called a Coke pouch, where you pass a catheter in to drain it, and you slip it back in and out. It's a pretty fancy thing. I've done them. We've done a few, but in general, if you're interested in that kind of thing, you'd probably be better off going to probably a major center like Cleveland Clinic or something like that, if you wanted a catheterizable stoma. The standard way we divert urine away from the bladder is it's a bag, basically. It's called a urostomy.
The bag is
outside the body, right? So it's coming off right about here, and it's just kind of hanging down, and it's under your clothes, so you really don't see it much, but it just kind of continuously drains into the bag. So it's like a colostomy, but it's urine coming out. And that's the way you divert the urine away from because you're taking the whole bladder. So that's called an ileal conduit, and that's the standard method. Now I also do a procedure called an ileal neobladder, where we take a larger piece of bowel and bring it down to the urethra. But for the same reason, you're not really a candidate for the robotic. That pretty much takes that out of the picture, I think. So it's really, from our standpoint, either the bag or some sort of an internal stoma that you catheterize. Okay. It's called an Indiana pouch. That's what that type of procedure is. But they all the surgical things for this, removing the bladders, it's a big operation. It's a 5 or 6 hour operation. You're in the hospital averages 7 to 10 days. It's a major operation.
Yeah.
So it's just and we presented your case, all 6 of us, 6 of us in our group. We've looked at all your X-rays and memorized, and we've presented it to the tumor conference and everything, and the radiologists were there, and we're all kind of in agreement, I think, that it's just not amenable to the robotic procedure, because we don't think we could get enough margins to make it.
So you would remove the bladder and the prostate.
They remove the bladder and the prostate, right? They're all. My
sister says, you don't want your bladder
Yeah, right. Well, go get a second opinion. I mean, it's a very rare thing, And
How could I get
if
a
you're going
second
down there,
opinion?
it's easy. You go there all the time. They'd be glad to see you anytime. They do this all the time.
I took all these tests.
Yeah, let's just bring them down. They'll look at them and they'll give you their opinion. That they do this all the time, and all the studies are easy, are good, and
What,
yeah,
this, how much longer could I go on
yeah.
without operation right now?
Well, you
What
did a
if-
lot. You
what-
you want.
What if Cleveland says, hey, we can't do you till
Right.
December?
Well, they're pretty good. They got a lot of capacity there, so you could, it doesn't hurt to go, and especially if you're going to be down in that area, it'd be a lot easier to follow up down there if you're going to be in that area, anyways. The follow up is important too for this. So you're going to need to be followed by somebody. So my way of looking at it, if you're going to be there already, you're probably best off treated there. That would be my feeling. I'm glad to treat you, but it's hard for you to have a major operation and then a month or two later you're gone and get follow up somewhere else. To me, that's not the ideal medicine. We'd like to follow people, So
It would take me months to move. I got things I got
right.
to do.
Well, yeah, but you could have it done. You could go down there. You could have it. Have to get the opinion, have it done, and then you could come back and move. Once you're healed up, you could move then. So.
Now, what
but,
about this?
mhm.
Well, there's a cancer center here.
Mhm.
Now, my
Yeah.
friend of mine's telling me
Yeah.
about the cancer center in
Yeah.
Philly.
Yeah. Oh yeah, there's all sorts of cancer centers.
Oh.
There's all major medical. Here in Boston, they have Dana Farber. Is glad to give you a second opinion.
What would the second opinion be?
Well, to say this is I've never seen this tumor. I mean, in my 30 years of urology, I've never seen it. So, they see more of the unusual tumors than the average. I'm a general urologist, and I certainly do cystectomies, and I feel comfortable doing them. That means removing the bladder. That's what the medical term is. But it's still, for this type of tumor, it's the more information you have and the more opinions you have, it's you don't want to regret or something, So and second opinions are easy. They're glad to see you and talk to you, and it's especially if you want to go Dana Farber, it's very easy. They'll see you within a week probably and give you their opinion. And if you wanted to, there's a bunch of people there that would be glad to do it too. So I think the more information you have, the better off you're served. But you want to get on this, certainly you want to be treated kind of certainly within the next month or.
Okay, let's pretend. Let's pretend I went to Dana Farber.
Right.
And tell them what I have.
Right.
They have to run all these tests on me again.
No, I don't think so.
Oh, you send them
they get all the information. It's there. They look at them, and our
From
radiologists are good. All our radiologists are good, and everything. Yeah. So the tests have been done. So I don't think they have to repeat much of anything. We've done the CT. We've done the MRI. You've had the bone scan. You've had the workup.
Yeah.
And so I don't think they'd have to repeat anything. I think they just give you their opinion of what's there. Yeah. It's easy to do. So
I'll need 7 days in the hospital.
Yeah.
And then I wouldn't be able to drive for a week or two.
Well, driving more like 3 to 4 weeks would probably 3 to 4 weeks. Yeah.
Even
it's a big
2 miles.
It's a big. It's right. It's a big operation. You feel weak for the first 2 or 3 months. You're feeling pretty weak.
Oh.
It's a big recovery.
Take pills.
Take pills for.
You're gonna give me you would give me take this medication.
For what? For pain or for thing? Well, we give medicines for pain, obviously, because there's an incision, and then whatever you need for nutrition. Nutrition's important and everything.
Yeah.
But it's still a big operation, and there's complications that can arise. We can go over all that. I've done 100 or probably more cystectomies over the years, and I've had one death. It was a guy that had terrible liver disease that had cirrhosis of the liver. Then he was he was very elderly. So it's not. It has its risks, but it's still, this cancer has its risks too, and you're not going to survive unless you have it treated. So.
Okay, this finasteride pills I'm taking, I'm going to run out in a week or two.
Okay.
Renew it again?
Oh yeah, sure, it doesn't hurt anything. You
What's
can
it
stay
do?
on it. It prevents the prostate from regrowing. But probably for your situation, it's probably not doing a heck of a lot, to tell you the truth. So
I mean, I think about a week ago it started, and even today when I urinate, much doesn't come out.
Yeah.
And Monday.
Right, because that means it's growing, and you could see. I mean, you could see by looking in there, it's growing. So.
Oh.
Yeah, you gotta get, you gotta get this figured out and taken care of.
Okay, because Monday I urinated for the first time in a month.
Right.
Blood came out in a couple pieces.
Right. So that just means you need to get things rolling. You need to get something done, because you're gonna all of a sudden you're gonna not be able to pee, and then you have to have catheters, and that can bleed, and then it's riskier surgery because there's a potential for infection and everything. So I think,
Well, I'm in hospital.
Yeah.
We'll have a catheter in the.
There's a catheter in the stoma and one from the penis.
Okay.
They're just temporary to drain things, but it's
So
right.
I'll never
So
urinate the right way again.
never urinate through the penis again. No.
And I'm not gonna make any
So-
friends
so-
if I hang around them. Just stand next to people I don't like.
No, it doesn't. It doesn't really. The hygiene is pretty good. I mean, I was talking about smell or something like that. Is what you're talking about? Or it's really not. There's professional golfers that have urostomies. There's a couple of them. That I know of. So it's pretty well tolerated by.
Last time I was in the hospital,
Yeah.
I guess something with HIPAA.
Yeah.
My sister,
Yeah.
she called in to
Right.
find out what room I was in.
Right.
They wouldn't tell her. Why
Right.
didn't you tell them? And
Right.
she wants me to make sure I take care of that.
Right. No, they give a list of people that you're okay to talk to and things. So, right. But I know it's not the news you wanted to hear, obviously, but it's you got one shot at this, is my feeling, and I just know from looking. We've looked inside. I did this initial surgery. We've seen the CAT scans. We've seen the MRIs, and we just don't think we can get good margins by doing it robotically.
Let me turn this. So if I said yes, right, I'll call my
Yeah,
sister.
sure.
But
Yeah.
if I said yes now, like
Yeah.
what, 2 weeks?
Yeah.
3 weeks from
We'd
now?
probably get you in within the next couple of weeks. Yeah, get it taken care of.
Yeah.
Mhm. Yep.
Okay, let me
Yep.
probably
Yeah.
tomorrow.
Yeah, talk to them. Talk it over, and if it's easy to get second opinions if that's what you want. We can just send everything, and they'll see it within a few days. Usually, they're pretty good at seeing people. They have a lot of capacity there. So,
Yeah,
yeah.
geez.
Yeah.
Yeah, you said it was growing. I thought maybe it
Yeah,
wasn't scraped all the way. I said, oh no, something's
it's
wrong
growing,
here.
It's growing. It's cancer. So cancer grows. Yep, that's what it does.
Yeah.
No.
You think we had an MRI
So-
a year or two ago, we would have found something? No.
No, I don't think so.
Oh.
No. And your prostate felt fine. I mean, on exam, it felt
Yeah.
normal. It wasn't firm or hard or anything. It was very normal feeling prostate. Your PSA was normal, so there's
Yeah.
just no way of knowing unless we got tissue, and we got tissue. So,
Boy,
yeah.
I had to go to the hospital that
Yeah.
October day.
yeah.
You know what?
I know it. Okay.
Okay, I'm going to talk to my
Yeah, talk to them.
family.
Call me. Let me know if you need whatever you want to do. Just let me know I'm here, and call me on the phone.